Hello, my name is Robin Thurman and I'm a maternal fetal medicine obstetrician, and I'm speaking to you today about influenza in pregnancy and also pertussis as well. So we'll be going through influenza, the pathogen, some epidemiology, talking about diagnosis and treatment, and then talking a little bit about pregnancy physiology, and then immunisation. Why is it so beneficial for the mother, the fetus and the infant, and if some of the strategies we have in place and recommendations, and then going on to pertussis vaccination in pregnancy. So influenza is broken up into influenza A and B, influenza C as well, although that one is not as big a pathogen for us. It is transmitted by droplet or aerosol spread, and we know that it can last outside the body for a significant amount of time. Influenza A is the one that causes the highest rate of morbidity and mortality, and it's due to the antigens on the outside, the H's or hemagglutinins, or the N's, the neuraminases, that change throughout time that lead to different strains, which mean that we need to have new vaccinations each year. So in the general population in Australia, you can see with the epidemiology that each year, in the graph on the right, marked out by different colours, there is a different sort of spread. Last year, the one in red, we had an earlier season that lasted for slightly longer, and there were over 298,000 cases of influenza and over 800 deaths in the community. This is a graph that shows the influenza admissions, or hospital admissions, from 2002 to 2013, and you can see that classic U shape where the older age group over 65s are particularly affected, but also it's this younger age group at the less than a year, and in particular 0 to 5 month group, which has a significant number of incidents per 100,000. This is really where the maternal vaccine is targeting, and I'll touch on this a little bit later, but you can see that these are the infants that are not able to get their own vaccine that we really need to think about when we're talking to our pregnant women. The diagnosis and investigations are the same as outside of pregnancy in the general population, but we do need to remember that pregnancy itself is a risk factor for severe disease, and so always thinking ahead and being proactive. So laboratory diagnosis is the same, really nasopharyngeal swab is the gold standard, and other investigations as may be required. The treatment in pregnancy is the same as the general population, but we do treat more in pregnancy. If you do have that diagnosis of influenza, then you should certainly treat straight away. And it is with antivirals, excuse me, commencing even when this clinical suspicion is there, even before the diagnosis has been made in the laboratory, and commencing treatment within 48 hours of symptoms is best. But if a woman is not improving and it's after 48 hours, then certainly please do commence antiviral therapy. The therapy is Tamiflu, which is oseltamivir, 75 milligrams orally BD for 5 days, which is the same in the non-pregnant population. There are other antivirals there that I've listed, but we don't tend to use those in pregnancy. So is influenza really that bad in pregnancy? You know, patients will say, well, everyone's had the flu, I've had the flu before, it's not such a big deal. But we certainly have seen in history through time, pandemics over the years, that it is worse for women and for pregnant women. And so the pandemic of 2009, the swine flu, we have some data locally that I'll talk about that showed that women were at increased risk for severe disease, hospitalisation, ICU admission, and unfortunately even death. So this is a study locally in Victoria. It's a small group of 43 women, but the outcomes of those women in the swine flu are significant, and unfortunately leading to even 1 maternal death and 3 fetal deaths, but plenty of other comorbidities there too. Why is it so bad? Well, if you look at respiratory physiology, it changes in pregnancy, and you can see that the fetus pushing up from below changes how the lungs work. So the spirometry is generally unchanged, but there's a reduction in residual volume, there's a reduction in chest wall compliance, and an increased blood volume. Combined with progesterone driving increased respiratory rate and increased minute ventilation, this leads to a decrease in PCO2 and therefore overall less physiological reserve. There are also some immune changes that occur through pregnancy, and in the 3rd trimester in particular, the woman's body is susceptible to infections, and influenza is one of those. So what can we do? Well, prevention, particularly in the coronavirus time now, we all know about hand washing and staying home when, to avoid getting in touch with other people that have these viruses, coughing into your elbow, etc. But really our main workhorse or weapon against it is immunisation. And so it's the quadrivalent influenza vaccine, which is used in pregnancy, so the same as the general population, the trivalent being only for the older age group over 65. Why do we use it? Well, it's for the mother, but it's also for the child. So vaccination in pregnancy increases the maternal antibodies, which then can cross through the placenta, the IgG, which then gives that protection to the fetus and then infant. There are no safety concerns with the vaccine for the 0 to 6 month age group, but unfortunately their body doesn't mount enough of a response for it to be for it to work, and so therefore there are no vaccines around the world that have been approved for use. So really, it's this maternal vaccination that is our best weapon against it. And so there are some college guidelines that we follow. This is the American guideline, which was published in 2018, and it says that all pregnant women in the influenza season should receive the vaccination. Healthcare workers ourselves should be vaccinated, and that we should treat women with any flu-like symptoms with antiviral medications, presumptively. And also thinking about post-exposure chemoprophylaxis. So this is for up to 2 weeks postpartum or pregnant women if they've been in close contact with someone who has had influenza infection confirmed. This is our Australian, the RANZCOG body, their guideline, which again is the same, saying that all women should have influenza vaccination in pregnancy, regardless of their gestation. So is it effective? Well, it is. It's about the same as in the general population, which this is a study from 2018 from Thompson et al., which showed that the overall influenza vaccine efficacy was 40%. In the general population, it depends on year to year the strain, and it really is from about 40 to 60%. This is a landmark paper that came out of New England Journal of Medicine. It was a randomised control trial in Bangladesh where they looked at the effectiveness of the maternal influenza immunisation for the mother and for the fetus or the infants, and it showed a reduction in the risk of respiratory illness in the women by 36%, a prevention of laboratory confirmed influenza in infants by 63%, and also a reduction of respiratory illness with fever that's not influenza of 29% in infants. And this is a graph that shows that. So the top line is the control. These women had pneumococcal vaccine, not the influenza, and then the influenza vaccine is that sort of beige line lower down. And this shows the cumulative cases of laboratory influenza in infants whose mother had received the vaccine. So you can see that these infants had fewer cases of influenza if their mother had the vaccine. So is it safe in pregnancy though? That is the biggest roadblock that I think we come across, is that women don't want to have the vaccine because they're worried about safety, and there certainly is good evidence that shows that it is. This is one paper in particular that I wanted to talk about that was published in 2016, and this showed that the stillbirth incidence in mothers who had had influenza vaccination was actually reduced. So the adjusted hazard ratio was 0.49, which means a 51% reduction in stillbirth when looking at thousands and thousands of women, and that certainly is impressive. So then if you look at a systematic review that was done locally by Michelle Giles and her team, they looked at 40 studies that were eligible, and they looked at various outcomes showing that there was a benefit or certainly no harm. So congenital anomalies, there was no significant increase or decrease in the risk of congenital anomalies associated with influenza vaccination. There was no increase or decrease in the risk of fetal death. There was actually a reduced risk of preterm birth associated with vaccination. There was no increase or decrease in small for gestational age babies, and then there was a reduced risk of low birth weight in mothers who had had the influenza vaccination. So certainly no negative outcomes here. Influenza and pertussis vaccination during pregnancy, this is a paper that shows from 2015 to 2017, what was the uptake? Well, it's actually not that great, so we do need to do some extra work. It was only 39% in this study, and this study really showed that women are more concerned about their infant or child's health, and that's where they see pertussis working, whereas they're not so concerned about their own health, or they are worried about any safety, and that's where they think of influenza. So there's a graph here that shows pertussis on the right and influenza on the left, and the blue bars are women that have been vaccinated against that disease. So from 2015 over to 2017, on the right, pertussis you can see gradually increasing as it has become more acceptable and women are aware of it and know that it's important for their child's health. However, influenza, it is seasonal. You can see that sort of going up and down, but it's only ever really gotten up to 60% in that study, and we really need to be working harder on that and informing women that it's not just for them, it certainly is for their fetus as well. This is available on the internet. Safer Care Victoria has our immunisation rates, and you can see each maternity hospital there, public and private. Overall the rate is about 53%, so we really need to keep working hard on this. It's also funded from the government, as I'm sure most of you know, so it is safe, it's effective and it's funded. So our pregnant women since 2010 have been getting free flu vaccinations, so we really need to keep working hard for them to get it. Pertussis, I'm going to touch on briefly, is another respiratory illness that's highly contagious. It's caused by gram-negative Coccobacillus B pertussis and is just found in humans. It has a significant morbidity and also can be fatal as well. And despite our vaccination programs, we do have peaks or different waves, outbreaks that come through every few years. Luckily, we've only had 2 deaths in Australia in the last 20 years, but in 2016 there were over 400 hospital admissions, and 38% of those were in the under 1 year age group. Immunisation is our best treatment or prevention against that as well, and this is the updated guideline from RANZCOG, which came out late last year in 2019, which shows that every woman should be vaccinated in pregnancy to get that transplacental antibody transfer. The ideal timing is 20 to 32 weeks, but really any time in pregnancy is okay. And if it doesn't happen in pregnancy, then try and get each woman postpartum and for each pregnancy, because as I said, it's not just about the woman, it's about her child as well. So in summary, pregnant women are particularly susceptible to having severe influenza infection, particularly in the 3rd trimester. Influenza infection can have adverse outcomes for the mother and for the baby, and we know that it is safe. The immunisation is safe, it's efficacious, it's recommended and it's funded, so we really need to keep going really hard with our flu vaccine program. And if someone does have flu in pregnancy, then treat early, treat on suspicion, and even if it is a little bit late, do that as well. Pertussis vaccination is recommended for every woman in each pregnancy, but ideally at 20 to 32 weeks. Thank you so much for listening today. I hope that that's been educational for you, and that we can all work together to improve our influenza immunisation in pregnancy and also pertussis as well. Thank you.